Hi everyone, my name is Desiree. I am in the Neurocognitive Disorders group. The first neurocognitive disorder that we are going to take a look at is delirium. So I'm just going to go through the DSM with you, kind of explain all of the diagnostic criteria for delirium and some of the other symptoms and parts and factors that go with it. So delirium has diagnostic criteria A through E. So A is a disturbance in attention, like reduced ability to direct, focus, sustain, and shift attention, and awareness, so reduced orientation to the environment. Criteria B is the disturbance develops over a short period of time, usually hours to a few days. It represents a change from baseline attention and awareness and tends to fluctuate in severity during the course of a day. Criteria C, an additional disturbance in cognition like memory deficit, disorientation, language, visuospatial ability, or perception. Criteria D is the disturbances in criteria A and C are not better explained by another pre-existing, established, or evolving neurocognitive disorder, and they do not in the context of severely reduced level of arousal, such as they did not occur, in the context of a severely reduced level of arousal, such as a coma. And then finally, E, there is evidence from the history, physical examination, or laboratory findings that the disturbance is a direct physiological consequence of another medical condition, substance intoxication or withdrawal, or exposure to a toxin, or is due to multiple etiologies. So a combination of all of those things. So there are different types of delirium. So in the DSM, they list substance withdrawal delirium. So it says the diagnosis should be made, instead of substance withdrawal when the symptoms and criteria A and C predominate in the clinical picture and when they are sufficiently severe to warrant clinical attention. So that's a little bit different than just substance withdrawal, like as a diagnosis by itself. And then medication-induced delirium is the diagnosis applies when the symptoms in criteria A and C arise as a side effect of a medication. So working in the medical field, I have seen, especially in the older population, they'll have a whole list of medications that they're on for an array of things, even, mentally, physically, whatever it may be. But then they have delirium as a side effect or as a symptom of one of those medications that's actually supposed to be treating something else. So it kind of takes away and it gets harder to diagnose. You really have to look at everything that a person is currently taking. Then we have delirium due to another medical condition. An example of that, again, working in the medical field, and especially with the older population, if someone has a urinary tract infection, they can become delirious. So it's kind of weird. It basically, the toxins from their urinary tract if it gets bad enough, get in their bloodstream, goes to their brain, and then they become delirious. So they don't know where they are or even who they are sometimes. Basically, any of the questions, if you ask who, what, when, where, why, if they miss any of those, it's a high possibility that they have an aspect of delirium for some reason. We have some specifiers in the DSM. So it says regarding course in hospital settings, delirium usually lasts about a week, but some symptoms often do persist even after the individual is discharged from the hospital. So individuals with delirium may rapidly switch between hyperactive and hypoactive states. The hyperactive state may be more common or more frequently recognized and is often associated with medication side effects and drug withdrawal. The hypoactive state may be more frequent in older adults, like I was talking about. Some diagnostic features. The essential feature of delirium is a disturbance in attention or awareness that is accompanied by a change in baseline cognition and cannot be better explained by a pre-existing or evolving neurocognitive disorder. So to have delirium, you can't also have something like dementia or Alzheimer's. They have to be separate. You have to differentiate them. Development and course of delirium. It says while the majority of individuals with delirium have a full recovery with or without treatment, early recognition and intervention usually shortens the duration of delirium. risk and prognostic factors. You have environmental, genetic, and physiological. So some of those environmental delirium may be increased in the context of functional impairment, immobility, a history of falls. Again, looking at the older population, if they fall, hit their head, they're on blood thinners, that's a big issue. And then genetic and physiological, both major and mild neurocognitive disorders can increase the risk for delirium and complicate the course. Older individuals are especially susceptible to delirium, like I was saying, compared with younger adults. Susceptibility to delirium in infancy and throughout childhood may be greater than in early and middle adulthood. And childhood delirium may be related to febrile illnesses and certain medications. So that makes me think of if you have febrile seizures due to a high fever or something, obviously you can't really tell if a baby is delirious, but you may be able to tell that as they develop throughout childhood. Some differential diagnoses, psychotic disorders, bipolar and depressive disorders with psychotic features, acute stress disorder, malingering and fictitious disorder, other neurocognitive disorders, which falls into just the other category. There's also an other specified delirium and unspecified delirium. So those apply. The other specified delirium applies to presentations in which symptoms characteristic of delirium that cause clinically significant distress or impairment in social, occupational, or other areas of functioning, but do not meet the full criteria. And it's pretty much the same for unspecified delirium. They cause clinically significant distress or impairment, but don't meet the full criteria for delirium or other disorders in the neurocognitive category. So that will conclude my part of our presentation. I hope you guys learned something, and I look forward to hearing your feedback. Thanks, guys.